Okay, so we are live. If anyone is connected, please let me know. Hello, Muhammad. It's a pleasure to meet you. If there are other participants, please let me know in the chat box. Do we have other participants? Hello, Shekhar. Pleased to meet you too. In 2 minutes we will start. So if there are any other participants, it is the moment to let us know your presence in the chat. Do we have any other participants? Okay, then let us start. All the participants, please let's comment in the chat to be able to have an interactive course. Perfect. So today we will talk on gastroenterology and gynecology. Our first case is a female of 25 years old who comes to the ED on Thanksgiving accusing of pain in her abdomen since her last meal 4 hours ago. She vomited on the way to the hospital. Her blood pressure is 120/80. She has 75 beats per minute as a pulse and 38 degrees Celsius. On palpation of the right upper quadrant, there is an inspiratory arrest on ERCP to administer IV fluids and antibiotics, to perform a cholecystectomy, or to perform a HIDA scan. Let me know your answer in the chat. We have a HIDA scan. We have a B, we administer IV fluids and antibiotics. Okay, could you tell us why? Also Shekhar and A, okay. Please tell us in the chat, why do you think the answer is A, B, or a HIDA scan? We have two eyes. So do we have ERCP to see if the stone has passed into CPD? Okay. Okay, so the reasoning here is that the patient has before we go and delve into the reasoning, let's go to the second question. Since these are NBME type questions, there are in the exam one after the other. So the patient is stabilized, and in the next 72 hours she develops jaundice, right upper quadrant pain, and fever. What is the most likely diagnosis with the new presentation? Acute cholecystitis, choledocholithiasis, or cholangitis? Please let me know your answers in the chat box. B, choledocholithiasis. Okay, Shekhar. This is one answer. Does anybody have any other opinion? Also a B. Okay. A cholecystitis, okay, Sadhana. This is another answer. Can we also have the reasoning behind B or cholecystitis? Would you like to explain why did you choose cholecystitis or choledocholithiasis? Okay. Someone said Charcot's triad. It's true. We have jaundice, right upper quadrant pain, and fever. Talha, tells us that the answer is cholangitis. Okay, now let's see the answers for these two questions. The first one was a HIDA scan, D. The second one was, as Talha said, cholangitis. Now, the patient presents with findings indicative for acute cholecystitis in the first part. When the ultrasound is not able to discern the stone, then the HIDA scan is the next indication for a diagnostic test. The radio tracer will not enhance the gallbladder in the case of acute cholecystitis. We had other answers such as ERCP. The ERCP in the case of acute cholecystitis is a treatment for acute cholecystitis. Also, for the gallstone that is lodged in the meantime in the second question, in the common bile duct, we have an infection that leads to acute cholangitis, therefore Charcot triad. And now the important point about these two questions is comparing acute cholecystitis with choledocholithiasis and with cholangitis. I would urge you to make a screenshot if you want to have this material going on forward. By definition, an acute cholecystitis is an inflammation of the gallbladder. Usually it is caused by gallstones. In comparison, choledocholithiasis is the obstruction of common bile duct, which can also be frequently caused by gallstones. Another instance for choledocholithiasis could be represented by strictures. Finally, cholangitis is the infection of the common bile duct. This can happen secondary to gallstones. On history and presentation, the acute cholecystitis has the Murphy sign, meaning that when the patient breathes in and the right upper quadrant is touched, the inspiration will halt. Also, the patient has right upper quadrant pain, she comes with low fever, and we have nausea and vomiting. On the other hand, choledocholithiasis is a condition that comes with a biliary colic but has jaundice, because the obstructed bilirubin will go into the blood flow, thus leading to bilirubin deposition inside the skin. And an important aspect of choledocholithiasis is that it can be with or without fever. Now, the last one, cholangitis, has a specific presentation, namely the Charcot triad, a right upper quadrant pain, fever, and jaundice. And it can also associate septic shock and altered mental status, leading to the Raynaud-Pentad. How do we diagnose each entity? Acute cholecystitis is diagnosed initially with ultrasound. If the ultrasound is equivocal, then we go for the HIDA scan, as we did in the previous question. On the other hand, for choledocholithiasis, we do not do only the ultrasound, but we do some lab work, namely we go with direct bilirubin and we see an increase in alkaline phosphatase. The important aspect of cholangitis on the lab work is the fact that it is an infection. Therefore, it will lead to leukocytosis and we will have positive blood cultures. We will also find an increase in direct bilirubin and alkaline phosphatase as cholestatic markers. The treatment for acute cholecystitis is represented initially by IV fluids and antibiotics. Once the patient has been stabilized, usually at 72 hours, then cholecystectomy is performed to avoid future crisis. Choledocholithiasis, on the other hand, as we explained previously, is treated with ERCP, and then cholecystectomy is applied to the patient. In the case of cholangitis, being an infection that leads to septic shock, not only that we give IV antibiotics, but we also admit to the ICU. The moment we have a Raynaud's pentad, we pursue to percutaneous cholecystectomy or ERCP without waiting for the patient to be stabilized due to the emergent nature and the life-threatening situation. Okay, do we have questions? Was it clear? Okay, Shekhar, so the questions were clear. If you have any feedback, please let me know in the chat box, or any question on these three entities, because at NBME and at the USMLEs, this differentiation between the three entities is usually tested as part of the gastroenterology section. Therefore, it is better to air now the misunderstanding than at the exam. This way you will have an enhanced score. Okay, so if there are no questions, we will pursue with the next vignette. Are we ready? Let me know in the chat section. Okay, so we are ready. Let's go to the next one. A woman presents to her physician for a breast lump that becomes larger during the beginning of her menstrual cycles. At palpation, the lump is painful, and it is not limited to the upper outer quadrant, but also spreads to the lower outer quadrant and the inner upper quadrant. The lesion is ultrasounded and biopsied. The pathologist reports a benign lesion. What is the most likely diagnosis? Fibroadenoma, Phyllodes tumor, fat necrosis, or fibrocystic changes? Let me know your answer and your reasoning in the chat. So we have a D from Sadhana, okay. Why D, Sadhana? Another D. Okay, could you, Shekhar and Sadhana, explain us why did you choose D? Fibroadenoma because of the estrogen effect from Talha, okay. Okay, gotcha. So, the answer is B, namely Phyllodes tumor. Although the lesion is benign and hormone responsive, indicating a possible fibroadenoma as Talha answered, it is also metastatic, meaning that it is not only in the upper outer quadrant, but also invades in the lower outer quadrant and in the inner outer quadrant. The Phyllodes tumor is the single benign lesion that has metastatic potential locally. Let's go a little bit more in depth. How does Phyllodes tumor versus fibroadenoma present on the physical exam? Both are hormone responsive benign tumors of the breast. Therefore, we expect that with the menstrual cycle, on the estrogen phase, both Phyllodes tumor and fibroadenoma will increase in their size. However, in the case of fibroadenoma, only 20% of the fibroadenomas are multilocular. Also, on the presentation in the vignette, we will have a smooth, round, mobile mass description. On the other hand, in the case of Phyllodes tumor, we will have a description of metastatic potential. Namely, it won't be contained and solitary as the fibroadenoma. So, let me know if you have any questions. Sadhana. Yes. The vignette didn't mention anything about the mobility of the tumor, but this was not the argument that could differentiate between those two. Sadhana, let me know if you have a question to. Let me know if you want me to be more clear, or if you have any misunderstanding. If there was any misunderstanding, sorry. Because it's painful. Muhammad, I understand your point, but Phyllodes tumor is not always a painful lesion. All the benign conditions, fibrocystic changes, fibroadenoma, and as well as Phyllodes tumor, can be asymptomatic. And I see that many of you chose D. In the case of fibrocystic changes, there will be a detail in the vignette that will state that they are usually bilateral, meaning that they are responsive to estrogen, or they can be, not always, but they are usually spread in both breasts. So let me know if you have any other questions on this vignette. Okay, Shekar. Please, if we have new participants, let me know in the chat box your name. This way we can interact more in a more fluent manner. Okay, are we all ready to pursue further? Okay, I'll take a minute to take a break and to suggest to check out the OBGYN related content. We have a live stream, a previous live stream on urology and OBGYN, and also we have an educational video on the fetal heart rate. The links are in the description of this live stream, so if you want to check it out after the end of the live stream, just go into the description and click on the links. We have another female of 26 years old that visits the family physician asking for OCPs as a contraception method. The medical records show a pattern of beads on a string at the renal angiography, for which she previously received beta blockers. Her mother suffers from obnoxious headaches that make her retreat to a dark room. There is no history of DVT in the patient. What is the contraindication for OCPs in this patient? DVT, hypertension, family history of migraines, or beta blockers? Please, when giving the answer in the chat box, explain the reasoning behind it so that we all understand the process behind it. Okay, please let me know your answers to the question. Dr. M. Muhammad Al-Saneh, how should I? Dr. Niha. Okay, so hi Niha and hi Dr. Muhammad. It's okay, Dr. Muhammad, to use this expression. B, we have D. Okay, so we have 3 answers. Do we have any other perspectives? Hirachana, another B. Shekhar also says B. Okay. So we kind of have an unanimity on B. Now, it is true, the contraindication is hypertension. And what are the OCP's contraindication? Usually it is a DVT, because OCPs increase the risk of thrombosis and also the risk of pulmonary embolism. Also, they are contraindicated in GERD because they act as a relaxant of the lower esophageal sphincter. They are contraindicated in hypertension due to the fact that they increase the blood pressure. And lastly, they increase the frequency of migraines with aura. Therefore, they are contraindicated in migraines with aura. Do you have any idea what is the mechanism behind the contraindication of OCPs to migraines with aura? So Sadhana says that progesterone causes vasodilation. Okay, this is an interesting perspective. Do we have also other proposal for the mechanism behind it? Okay, so the OCPs have more mechanisms through which they increase the frequency of migraines with aura. As Sadhana mentioned before, one of them is vasodilation through progesterone. Also, there is an estrogen effect that sensitizes the receptors, usually for pain, but also the receptors for serotonin. Therefore, migraines that are caused by an imbalance in the serotonin system will be more frequent with estrogen-based combined contraceptives. Okay, was this question and clinical vignette clear? Do you have any questions? Neha, yes, indeed, they increase the chance of stroke. Let me, because I didn't see the question right for the first time. So, Neha asked, Neha, hopefully I read the name correctly, asked if the OCPs increase the chances of stroke by thrombus formation. So, the OCPs predispose to formation of thrombi in the venous system, namely leading to deep vein thrombosis or to pulmonary embolism. The question, if it can create a stroke, targets the arterial system, a thrombus formation in the arterial system. The single way when a patient on OCPs can develop a stroke is if she develops a deep vein thrombosis that will go up to the right atrium, and in the presence of a patent foramen ovale, it will lead to a paradoxical emboli. This thrombus from the right atrium will go into the left atrium, and then it will enter the systemic circulation, leading to a stroke. This is the single type of event, OCP related, that can lead to stroke. Was the explanation clear, Neha? Can we go further with the next vignette? With pleasure. I'm pleased that all of you are learning and are preparing for the MBMEs and the USMLEs, and that this helps you and brings you value. Okay, let's pursue the last vignette. A neonate vomits and drools with his first feeding. He becomes cyanotic. The nurse tries to introduce a nasogastric tube without any success. At the low-dose chest X-ray, there is no air in the stomach. What is the most likely diagnosis? Pure tracheoesophageal fistula, tracheoesophageal fistula type E, pure esophageal atresia, tracheoesophageal fistula type A, or esophageal atresia with distal tracheoesophageal fistula, TEF type C. Let me know your answer. Okay, we have an answer from Talha, who says that it is a pure esophageal atresia because there is no air in the stomach. Do we have any other answers? B. Okay, another B. B, resistance to NG-Q-tube. Okay, so I have to say that Rachana, Neha, Shekhar, Muhammad, and Talha, you were all right. The explanation is indeed based on the chest X-ray. A tracheoesophageal fistula presents indeed with drooling, vomiting and choking on first feeding, and cyanosis, laryngospasms on liquid entering the airways. The difference between these types is that the air bubble is seen when there is a communication with the respiratory system. If we have a distal tracheoesophageal fistula, although we have an esophageal atresia, we have still a communication with the respiratory system that leads to the air bubble. If we have a pure tracheoesophageal fistula, again, the respiratory system communicates with the digestive tract, leading to the air bubble formation. However, if there is no communication between the respiratory system and the stomach, then we have no air in the stomach. Okay, did you have any questions on this topic? Sadhana, you're right. Yes, Talhaz, indeed, there are 5 types, but usually just the C type, the E type, and the A type are tested inside the NBMEs, because D and B types are very rare. The most common one indeed is TEF type C, esophageal atresia with distal tracheoesophageal fistula. Right. Are there any questions on the topics that we covered? Okay, so there's no questions. If you'd like a free weekly newsletter with summary sheets to prepare for NBME or for your rounds, you can send an email to medicalperspectiveblog@gmail.com. Also, we have a previous form that is still open. It is for an Ambos discount. We still need 20 participants to obtain the discount for their products. They kindly sponsored this initiative, so if you want to complete the form, I will let the form in the chat box. Okay. If you want to partake to the next Livestream course, it will take part in the next 2 weeks, most probably on the 7th of May. You can subscribe to the channel to be notified when the live stream will be online. Also, you can check on Reddit on the Step 2 or on the USMLE groups, where the post with the topic choice will be published. Every 2 weeks there is a poll for which topics do you want to have on the live stream. Okay, Shekhar, Sadhana, Talha, Neha, Rachana, Muhammad, I'm grateful that you attended on today's class, and I hope that you learned. Also, please let me know in the chat if you got value from this course. With pleasure. I hope you'll tune in on 7th May for the next course. Well, that's it for tonight, or for today. It depends on where you are on the planet. And I hope you will have a nice weekend. Bye.